Halo everyone, selamat siang semuanya.
Tapi ada juga jenis kanker yang memang kadang itu tidak tampak di awal, tapi sebenarnya prosesnya sudah lama. Jadi kadang-kadang sudah diketahui stadium lanjutnya.
Yang belakang yang ini bisa di-mute.
Beberapa penelitian yang
sebentar, kita lagi tes suara. Apakah terdengar semuanya?
Kedengar.
Kedengar, nggak ada back sound ya?
Nggak ada.
Oke, terima kasih banyak. Sebelumnya terima kasih banyak semuanya sudah bersedia hadir. Di sini siapa yang saya kenal ya? Ada Deris Lei, thank you very much for coming. Terus ada Mbak Riri, Dr. Wanarani, Profesor Wijaya Laksmi, terima kasih banyak. Dan mungkin nanti juga akan ada lagi yang lainnya. Ini belum mulai, sebentar lagi, kira-kira mungkin 1 menit lagi. Kita sedang siap-siap dulu. Karena cukup ini, karena kita pakai 2 laptop, jadi kadang ada background voice. Nanti yang tidak berbicara, mohon dimatikan dulu mikrofonnya. Professor, I'm checking this one. The YouTube, because maybe there will be some people on YouTube. Yeah, okay. So, can we start? Yes, okay. Assalamualaikum, selamat siang untuk yang ada di Indonesia, teman-teman di Indonesia. Mungkin agak selamat sore ya untuk yang ada di Indonesia Timur, karena saya lihat tadi ada yang dari Papua juga. Sekarang saya kedatangan tamu Profesor Gutenbrunner di channel YouTube saya. Ini tentunya merupakan, I feel honored to have you here, Profesor Gutenbrunner, that finally you are here and in the live occasion. Karena Profesor Gutenbrunner sebetulnya sudah ngisi juga acara di channel YouTube saya beberapa kali, mungkin bisa dilihat nanti teman-teman yang penasaran. Juga kita sebelumnya mendiskusikan tentang rehabilitasi dan COVID, rehabilitasi pada health system secara global, dan juga dia bereaksi terhadap traditional medicine, yaitu kerokan di Indonesia. Nanti bisa dilihat juga terkait itu. Tapi untuk sekarang kita akan mendiskusikan lebih ke arah long COVID dan kaitannya dengan rehabilitasi. Tapi tentunya bisa juga menanyakan selain long COVID-nya, bisa dari fase akut juga. Nah, ini jadi aturannya adalah karena ngobrol santai konsepnya, jadi semua orang nanti bisa bertanya, tapi tentunya nanti dimulai dulu, pertanyaan akan dimulai dari saya ke beliau. Nanti di tengah-tengah jika ada rekan-rekan baik di Zoom maupun di YouTube ingin bertanya, silahkan bertanya, tapi raise hand dulu gitu ya. Nanti akan saya izinkan siapa yang duluan bisa bertanya. Nah, sebelumnya akan saya bacakan dulu CV terkait dengan Profesor Gutenbrunner. Jadi Profesor Gutenbrunner ini adalah dia Head of Department dari Rehabilitation Medicine di Hannover Medical School sejak tahun 2007. Kemudian beliau juga Presiden dari German Society of Physical and Rehabilitation Medicine. 3 kali menjabat sebetulnya beliau ini, mungkin 10 tahun yang lalu, kemudian terakhir adalah periode yang lalu. Sekarang beliau sudah tidak lagi menjadi presiden dari German Society of Physical Rehabilitation Medicine. Beliau juga pernah menjabat sebagai presiden dari Baltic North Sea Forum on Physical and Rehabilitation Medicine. Kemudian beliau juga menjadi pionir, yaitu pendiri dari salah satu pendiri dari Global Rehabilitation Alliance, dan pernah menjadi juga
Sorry, Boya, we can't hear you. Boya, we can't hear you.
Can you hear me?
Okay, we can.
Okay.
This we have to be aware.
So okay.
Please not.
Yeah, okay, please. I'm sorry because this cable connection has some issue. Ya, kemudian apa lagi? Oke, itu saja introduksinya siapa itu Profesor Gutenbrunner. Jadi kita akan langsung sekarang ke materinya. Nah, Profesor Gutenbrunner, good morning. How are you today?
Yeah. Good morning or good afternoon to those colleagues and friends and listeners from Indonesia. Good afternoon. Salam alaikum. I'm fine. And I'm excited to be part of this meeting here, and hopefully we have a good discussion and also questions and answers, not only to give lecture.
Okay, thank you very much. In this occasion, Professor Gutenbrunner will not give any PowerPoint presentation. We just talk and discuss directly. So it is really relaxed, in the relaxed way, informal, I can say. But yeah, we are here now even in the Professor Gutenbrunner's office, but we still can do in a relaxed way. Now, Professor Gutenbrunner, since a few weeks ago, including in Europe and particularly in Germany, COVID again have been increasing. Although it is, let's say, mostly Omicron, yeah, but still some people maybe not so much concerned about this Omicron because mostly the symptoms are very light, but maybe for some patients it could be also severe. And we also still have a Delta in this case because we cannot neglect this Delta variant also. And now in Indonesia also since 2 or 3 weeks ago also have been increasing again this situation. And maybe because this situation is really relevant with our topic, particularly for the long COVID patient or survivor, maybe before we go to that case, could you please maybe explain a little bit, because there is here our audience not only rehabilitation expert who are attend, maybe also some other people who are interested in this issue. Maybe could you please tell us about the rehabilitation needs for COVID patients, but briefly, because maybe we'll have another question.
Yes. Well, just to explain a little bit to the Indonesian colleagues what the situation is in Germany at the moment. I think this is quite important to be aware of this. So you know, and it will be the same in Indonesia, that we have different types or subtypes of the virus, the SARS-CoV-2 virus. And the important thing is to know about these subtypes or variants, how many people will be infected by one person. So how much infections will occur from one. So this is infectiosity, or how we can call it, and the other one is the severity of the disease. And we observe that in the new variant called Omicron, we see that much more people are infected. So we have a huge increase of infections, but we have only a very small or light increase of severe diseases. So we have a situation that we have more infections, but less severe, and also less people dying. With regard to rehabilitation, what does that mean? The situation that Omicron replaces Delta variant, that means that we still have a need for rehabilitation in the acute phase, because some of the patients still have to be in the intensive care with artificial respiration or other treatments. So we need to do the rehabilitation there, because we know the early rehabilitation is very important also for the long-term outcomes, and also relevant for those people who have problems with the respiratory system. This is one point. There's another point that we observe from the Delta, but also from the Alpha and the other variants, that they have long-term problems, or patients that have been affected in a high number have long-term problems. And that's where the long-term rehabilitation comes in. And I think we will discuss this more in detail. What we do not know yet and we have been asked this many times, do we know how many people will have long COVID or long-term symptoms after Omicron infection? We don't know this yet because Omicron is only since a few months here in Germany, so we do not have this data. But we expect, of course, there will be long-term sequelae, as we call it, but hopefully in less percentage of infected people.
Okay. Thank you very much. This is very important information. And then I also read information on some research or literature or even in the news, because now COVID is still trending. Yeah, so if there is a new information from the research, so it will be also become a big news everywhere in the world. So I read about there is about 100 million people suffering with a long COVID symptoms. On how about your view on this one, and how about in Germany situation of this one?
Yeah, that's very important. And interestingly, if we look at the development of the pandemic and the consequences of the pandemic, there were quite early reports from China, from Wuhan in China, that after the acute infection is over, some people or many people suffer from other problems. I will come back to this later. We observe it since 2020 in Germany, and since autumn in 2020, we already established a rehab service for long COVID symptoms here in Hanover Medical School. So we have almost 1.5 years of experience to help these and to rehabilitate these patients. The problem is here that we do not have, well, exact numbers. We have estimations how many people who have been severely infected may develop these long-term problems. Some studies say 10%, others say 20%. So between 10 and 20%, we estimate the number of people with long-term problems.
Okay.
One important point, before I forget it, we see the long-term problems, of course, in patients that had a severe acute phase.
Yeah.
Being hospitalized, being in intensive care unit, or severely sick. Interestingly, we also see some long-term problems in patients that had not a severe acute disease. So even if the acute disease is mild, long-term problems may occur. And that is the difficulty sometimes in the interpretation. If we see a person, well, I was not really so much sick. I had some flu symptoms, let me say like only that. Mild, only a few days. But then, in some cases, after 2 weeks or after 4 weeks, new symptoms occur, like being fatigued, being tired, having problems with concentration, and many other problems may occur. And this is also possible in patients with light initial symptoms.
Okay, this is very interesting. Oh yeah, thank you, Professor Gutenbrunner, for this explanation. I need to explain to the audience because there is some concern from one of audience. Do we already have, why we do not wear mask, and also we already get antigen test before or not? Yeah, actually in Germany there is a regulation. If people already have the booster, we do not need to have a mask anymore and antigen test when we talk, particularly if it is only a few people inside of the room. But of course, for people who only have full vaccinated only 2, so they need to have a test. But because we already have a booster, so we do not need. Thank you very much for this concern, very important. So, Professor Gutenbrunner, you already mentioned this issue. This is very important. As you mentioned that, do you find any differences for this type of long COVID patient or survivor? Maybe some people have, for example, only fatigue or only a physical, but maybe the other only have mental. Is it also related what occurred before, or it is just randomly like that?
Well, you know, and many of the experts here in the room know that there is a definition of post-COVID and long-COVID, and this definition relates to the duration of symptoms. So if you have less than 12 weeks, then it's called the long COVID or prolonged COVID, or if it's longer, it's called the post-COVID. From my clinical experience, and I explicitly talk about my clinical experience, this does not make the real differentiation we need. And as you mentioned, if we look at the patients, I can see from my experience that there are three main types or groups of patients that have some similarities. Of course, there's overlap in between the groups. And the first group is a group that had a severe disease, severe lung symptoms, but also in the acute phase, for instance, symptoms from the brain and from the cardiovascular symptoms or from the kidneys and others. Those patients had an acute organ damage, let me say like that. They had organ problems we can see in the X-ray or the other imaging techniques. And those people had a delayed recovery. So the symptoms they had in the acute phase are improving, but not vanishing. So they have a prolonged recreation or recovery process. This is one group with the organ problems. But we see another group of patients, and those are in many cases patients with not so severe acute symptoms that develop new symptoms after the end of the acute phase. And those symptoms are, as you mentioned, mainly predominant is the fatigue. So feeling tired even after sleeping, and the fatigue is physical. So it's my body feels fatigued or feels tired, but it is also about concentration. So I cannot, concentrations, memory functions and things like that. And also including mood functions. So feeling depressed, not having maybe a major depression, but feeling depressed, feeling lack of energy, lack of drive in the activities. And this is then a symptom that is not the same, but has some similarities with the fatigue syndrome we also observe in cancer patients. So this is let me say like that, even this term is not scientifically defined, it's a post-COVID fatigue syndrome with lots of symptoms, but this is a little bit different from those who have the organ. And then you mentioned a third issue or problem in your question, that is, what about the situation or the disease of the patient before the infection? And maybe also some effects I would like to add of the pandemic situation or the regulations we have. And I think this has been the same in Indonesia. In Germany, it was very strong. We had the lockdown. We had the problem that people had to go to the test, things like that. They had the problem that the children could not go to school. So there was a lot of stress also in the families and many, many other things. And this is a psychosocial stress. And of course, if you you have maybe some situation where you are sensitive to such a psychosocial stress situation, your symptoms can be stronger. For instance, we see that in chronic pain patients and other patients that have psychosomatic, as we call it in Germany, psychosomatic complaints, this also can be increased, but then it's not directly the infection that causes this, so it's the stress situation related to the pandemic. So I see these three types of patients, and looking at we are also scientists, we at the moment developed a questionnaire to differentiate, but we are testing this questionnaire. So from the clinical observation and from the understanding of the disease, I think it is quite clear. However, we have to say the limitation is that the scientific research on this is still ongoing.
Okay, this is also very important information. Yang hadir, jika ada pertanyaan, silahkan raise hand. Jika nggak pede pakai bahasa Inggris, silakan pakai bahasa Indonesia. Nanti akan saya coba untuk menerjemahkan. Ya, terima kasih. Dan barusan ada yang tanya lagi ke saya, apakah booster ketiga saja atau diulang setiap 6 bulan? Jadi sebetulnya di pemerintah Jerman belum mengeluarkan lagi peraturan yang betul-betul secara resmi ya, apakah nanti 6 bulan harus di booster, harus divaksin lagi. Jadi kita masih nunggu. Jadi sekarang masih baru booster aja, karena booster sendiri baru dimulai akhir Oktober kemarin kalau nggak salah, dan saya sendiri dapatnya bulan November kemarin. Terima kasih banyak atas pertanyaan dan concern-nya. Nah, Profesor Gutenbrunner, as you already mentioned, maybe some people also who are not working in the field of rehabilitation here, because I also see my friends who are not physician, for example, they also would like to know how is the treatment of rehabilitation since acute phase of the COVID, maybe. Could you please just elaborate a little bit?
Yeah. Well, for the rehabilitation, of course, we have the, let's say, the goal to improve or to support and to improve body functions in this case, but also the activities and the reintegration into the society. And in the acute phase, of course, rehabilitation interventions will not be able to directly address the disease. So the infection needs to be treated by other means. But we know that it is very important to support body functions that are involved in the disease. For instance, lung function is a very important point, and we can have the artificial respiration where we put oxygen, let's say we press oxygen to the lungs that then will be absorbed and well utilized in the blood. But we also need to see how the breathing pattern works. For instance, how you do the inspiration, the expiration. Do you use the belly and also only the chest or something like that? So this is very important to do this, and this is it is very important in all the phases, but it is extremely important if you remove the artificial respiration, the mechanical respiration, and come back to the spontaneous respiration. And for this, we need respiration treatment, which is a rehabilitation treatment, which is extremely important. Another very important part for the acute phase is that if you are in the intensive care, but also if you're lying in the bed, a lot of body functions will go down, will decrease. For instance, cardiovascular regulation. If you lay in bed for 1 week, for instance, and then get up, you will faint. Or there's a risk of fainting. And so we need to do the training. We need to do a very graduated early mobilization, first sitting up, then sitting up with the legs outside the bed, and standing up with assistance. So we need to train these functions in the early phase. And we know from other diseases that these early rehabilitation interventions in the hospital will lead to better long-term outcomes. So as if you intervene very early, you can avoid that the functions going down, further down. So you stop the process of functions going down and even can start to increase. And if you see this as a curve, if you, for instance, have a curve of going down of functions and then start here to recover, you have a lower level. If you start earlier, you will have a higher level. So we know that this should be applied as early as possible for avoiding the process of functional decrease and to turn this around to a improvement. That's for the acute.
Okay, maybe because maybe another important message that it also can avoid the disability after the patients recover in the end. That's very much important.
Or to reduce the risk. Avoid is maybe too much. Okay, it's always gradual what we are doing.
Okay, thank you very much. This is very important term also. Yang baru hadir, jika ingin bertanya silakan raise hand, nanti akan saya persilahkan. Bisa juga open mic. Kalau tidak pede dengan bahasa Inggrisnya, bisa pakai bahasa Indonesia, nanti saya coba terjemahkan. Dan yang di YouTube juga, jika ada pertanyaan silakan. Profesor Gutenbrunner, You mentioned that here in our department we also do research related to the COVID patient, and do you also have specific treatment for them, maybe, or it is
Yes.
just? Could you please just elaborate?
Yes, well, this is another very important question. What can we do if we have the prolonged causes of the disease, or we have the post-COVID disease with a new symptoms? And of course, as you know, normally we choose our treatments from scientific studies that show us that there is evidence-based like that. But for the long COVID, we cannot do it directly because we have no long-term studies. Because it's a new disease and it's a new problem. But it does not hinder us to do a meaningful intervention, because we know, of course, all these symptoms that occur in the patients. Like I mentioned, fatigue is also in some rheumatoid diseases, in some in cancer survivors, and in other diseases, we see the phenomenon of fatigue. And for the fatigue caused by other diseases, we have evidence. We know the studies that they know. And what we do is, for all the symptoms we see, we look at the evidence we have from similar, let me say, similar diseases, and then we apply it. And as the symptoms are quite broad, we need many different types of intervention. For instance, for fatigue, it is the aerobic exercise, so endurance training on the treadmill or outside. We can do it in different ways. You need to have methods that influence sleep wakefulness regulation. For this could be done by cold applications in the morning, but also physical training in the morning. But we have more specific treatments. For instance, if we have a pain patient, or if we have the problems of the smell and taste, then we have a training set to train this. So we do it in the symptoms. If we have the problems with the memory, we do the memory training at the computer with computer programs. So we choose for each symptom the method we know from other diseases. And due to our observation, but it's just an observation, this is really helpful. So even in long COVID, it works, but the studies need to be done.
Okay. So how long have this study performed actually in our department?
Well, let me say, we already in the very early phase made let me say, a pragmatic approach.
Okay.
To say we see the people suffering from specific symptoms, and we treated the symptoms. This is not a study as such. This is just an application of the knowledge.
Okay.
And it also is published you can read this in the American Journal of Physical Medicine and Rehabilitation. So this is published, and we do it. And now we do just observational looking if it works. What we see, and this is especially for the patients with the organ-specific damage, that it is very difficult to treat. And we have some patients we treat even since months, and they still have the symptoms.
Could you please mention which organ?
It's mainly the lung,
or
the cardiovascular system, but it could also be the brain deficits. And we have a huge problem, to be very honest, for instance, to get the people back to work. This is not only the elderly people, it's people my age and younger, your age, and those people also have these chronic issues, so that we have to see how to manage also their work capability, which is also part of rehabilitation. So return to work is one of rehabilitation goals. And this is still very difficult. I must be honest in this. Even we have slight improvements. Some of the patients really have long-term problems, even with professional vocational performance.
Okay, yeah. Because I also read in the news, I think in BBC some times ago, that people no, she already recovered from COVID, but I think she's under 30 years old, but she's still in the.
Okay. Okay.
The license. Hello, can you hear us?
Yes, we can hear you.
Okay. I'm sorry. Yeah. Okay. Yeah. Sorry. Now I forgot what need to be asked. Okay. Yeah, because I also see the in the news in the BBC that there was a young woman under 30 years old. She just recovered from the COVID, but she said, "I'm not fit anymore to go to work." But and then maybe some people who do not know these symptoms, for example, maybe they were curious. For example, you mentioned that if you are fatigued, and then you will give a prescription to have aerobic exercise. Maybe the lay people will say, "Hey, I have fatigue. Why should I do exercise? It will make me more fatigued."
Yeah. So there's one thing I feel that is important to be aware of.
Yes.
We have some treatments to improve the symptoms of the long COVID.
Okay.
There's no doubt. But I'm not sure if we really can cure it.
Okay, I see.
So in many cases, this is gradual. So we can improve, but maybe we cannot reach the full recovery.
Mm-hmm.
And I think this is very important to mention it here, that even if you think your risk to have a severe infection is not so big because you are young, you are fit and things like that. You should avoid to be infected because the risk of long COVID may be still there. So the best management of long COVID is the vaccination for the acute disease. Okay. I think this is very important, and we focus very much on the acute, but then we see to avoid people dying. That's very important. That's the key. But we also with the vaccination can avoid the long COVID. That's one thing. The second is the very important problem is if you are suffering from fatigue and you should exercise, exactly what you say will occur. I cannot. And there are two aspects of this. We know that in some patients with fatigue after COVID, we see the phenomenon of, it's called the post-exertional malaise. This is a symptom or syndrome that if you have fatigue, you exercise, your performance will drop down dramatically. Okay. So you have no resistance for the exercise. Okay. And in these cases, it makes sense to treat the fatigue with other symptoms. For instance, with sleep-wake regulation, with cold stimuli, or going to fresh air and things like that, to have more mild interventions for those patients. Okay. That is clear. So fatigue is not equal to fatigue. There are different subtypes even here too. But on the other hand, it's exactly what we need to do is if people cannot go to work, we need to support them, and we need rehabilitation programs. And we fight also in Germany that we say for long COVID, we need an effort to increase the capacity and also the quality of rehabilitation programs, which even has been seen by the regional parliament, and they say we need more rehabilitation. And maybe this could be an issue also for Indonesia. I could imagine that the rehabilitation system must also expand and be developed to deal with the problem of the long COVID.
Yeah, okay, I can understand. Yeah. I just saw a publication actually in BMJ, I think this morning, that people who get fully vaccinated, it also will reduce the to have long COVID symptoms. What do you think about this one?
Yeah, I haven't read the study this morning, so
okay.
Unfortunately, I just read the newspaper this morning, so I'm sorry for that. You are more updated, but I think this is definitely true. So if we understand the mechanism of the long COVID, one is related to organ damage in the acute phase. Another one is the reaction to the severe disease, which most probably is the consequence of the immune reaction to the disease. So we have the organ problem, and we have the reaction of the immune system. And most probably, the reactions of the immune systems are the cause of the long COVID. So if you avoid the infection, damaging the organ, and also avoid the immune storm, as we call it, then of course there's a risk you will not have the long-term consequences. So I think this is definitely true from my experience, even if I could not read this paper this morning.
Okay, we have a question from Dr. Maria Evadana. Could you please open your mic? You can ask directly. I'm sorry for the technical issue here. No, it's okay. So, Dr. Maria, please.
Okay. Good morning, Professor Gutenbrunner and Dr. Boya. I'm Dana, Physical Medicine and Rehabilitation from Jakarta. I want to ask you, do you have any experience with a patient who's getting better with the respiration problem after you give her or him psychiatric medicine like anti-anxiety or anti-depression?
Well, I cannot answer this directly. Well, the relation to the anxiety and depression is, of course, that this may influence the physical activity, the daily physical activity. So if you are depressed, you know that you will move less, and so you will have a vicious circle of depression, of less physical activity, decreasing lung function and such. So if you want to interrupt this mechanism, if you see a patient because of the depression will not do the daily activity, then I think it makes sense also to work with antidepressants, but it is not a direct mechanism, it's an indirect mechanism. And this could make sense. I think we should not say this is for every patient, but in the individual case, it could make sense.
Gimana? Do you feel satisfied or do you have follow-up questions, please?
I mean, if the patient is very anxiety, and then you give because of the air hunger, and then you give anti-anxiety, is there any improvement?
Well, yes. Well, I think, of course, the anxiety symptoms or the depressive symptoms you see in long COVID patients, you can treat with the standard you treat normally. And of course, this is part of the, let's say, multidimensional symptom. So we think we should do this in the case from our analysis as physical and rehabilitation medicine doctors. From the analysis, we see that there is a problem in the individual, then we should also use this kind of medication. What we at this point have to do, and this makes it a little bit difficult, that we see the individuals have different symptoms and different interaction of these symptoms. That's why we need to analyze the need of rehabilitation. We cannot do this, let's say, mechanically. So we need to, and this is very important, we say that here we need centers to assess the needs of a person, an individual patient, what is needed there. And then, of course, in some cases, what you say exactly needs to be done. In other cases, maybe we need another approach.
Bagaimana?
Okay, thank you very much.
Yeah.
Okay, thank you for your question. Here I have another question in the Zoom chat. Dr. Bona Pardede, would you like to open mic or I just read it? Gimana? Mau saya bacakan aja atau mau langsung? Sepertinya saya bacakan saja ya, dia langsung direct message ke saya. Could you please tell us how to assess fatigue objectively and subjectively?
Yes. Thank you for this question. This is, of course, an essential part of the physical and rehabilitation medicine. What we do, we use the fatigue questionnaires. There are a number of fatigue questionnaires that gives by, to be filled in by the patients, and then we see the points and we see something on the severity. This is one to, let me say, it's semi-objective. Of course, we can ask the patients in the history, taking the history, patients will describe it, but we have a way with the questionnaires to have a semi-objective value, and we also can see the severity. We also have some questionnaires that differentiate, and this is for me as a clinician very important, to differentiate in between the physical fatigue, the mental fatigue, which also has been mentioned here, for instance, with the depressive symptoms, and the cognitive fatigue. So these three parts can be differentiated. What are we doing here in Hanover Medical School is all patients who come to the long COVID services, they have to fill in one generic fatigue questionnaire. Then we have the doctor's the discussion with the doctor. And then if we see there's a relevant fatigue, we will hand them out another questionnaire that makes a differentiation. You talked about the objective criteria. Also, we have the semi-objective. The objective criteria of course, we cannot measure directly fatigue. That's not possible, but we can measure some aspects, of course, which is concentration test. To see how good they fulfill, for instance, computer tasks, standardized computer tasks. We also can measure autonomous regulation, which may be included there. So we can have some aspects of the fatigue, but this is not the whole picture. So we have the subjective, what patients tell us, the semi-objective, which is the questionnaires, and some aspects of it can be measured by objective. So sorry giving such a complicated answer, but it's a complicated field.
Yes.
Because we have no imaging or something like that of the fatigue itself.
Okay, thank you very much, Dr. Gutenbrunner. Ini pertanyaannya sebetulnya ada lanjutannya ya. Kira-kira nih rekan-rekan dokter di Indonesia ada nggak yang bisa bantu jawab? Kira-kira apa bahasa Indonesia yang cocok untuk fatigue? Secara keluhan juga fatigue masih jarang dikeluhkan oleh Indonesia di sini. Kalau secara ini sih sebetulnya lelah ya, tapi mungkin rekan-rekan PRM physician yang ada di Indonesia mungkin bisa yang tahu, yang kebanyakan digunakan istilah fatigue di Indonesia itu apa, silahkan mohon dibantu menjawabnya. Sebetulnya terkait dengan keluhan fatigue mungkin bisa juga kita melihat dari sisi psychological problem. Sebetulnya tahun kemarin saya dilibatkan oleh rekan dari Unair untuk membuat kuesioner yang secara umum terkait dengan assessment rehabilitasi untuk rehabilitasi treatment secara umum. Nah, saya awalnya dokter dari Unair itu tidak langsung mengikut sertakan parameter terkait psikologi. Alasannya kenapa? Karena di Indonesia katanya masih kurang umum dan orang-orang awam tuh masih belum mau terbuka terkait masalah psychological problem. Tapi alhamdulillah ujung-ujungnya mereka menyetujui untuk memasukkan salah satu parameter psychological problem di situ. Karena bagaimanapun kita harus harus melihat pasien secara keseluruhan, bukan hanya dari physical problem tapi juga mental health problem. Karena nanti pendekatan untuk rehabilitation treatment-nya juga bakalan lebih holistik dan outcome-nya juga lebih bagus. Jadi untuk kira-kira apa yang cocok istilah fatigue, mungkin nanti bisa ditanyakan langsung untuk bahasa Indonesia ya, bisa tanyakan langsung ke dokter rehab yang ada di Indonesia, karena saya tidak tahu apa di Indonesia istilah yang digunakan. Tapi kalau misalkan secara literally bahasa Inggrisnya itu rasa lelah, fatigue itu.
May I?
Do you understand?
No, not really. But
Okay.
I heard you talking about psychological problems.
Okay.
And I think this is important also to reflect here. We have in the discussion forum here,
Yes, okay.
and I feel what we need to be aware that what we see as, let's say, mental or psychological problem also is related to the regulation within the body, to physical. We cannot say, maybe we can say psychological problems if you have a conflict, a psychosocial problem, and then you need to see this is on the level of the mental situation. For instance, if we have a conflict, of course we feel bad, and maybe we need, if it's chronic, to have some interventions. But what we see here in the long COVID is a problem of dysregulation, which has a physical aspect, which is regulation, and it also has a mental aspect within mood or also feeling pain. We know this also from the chronic pain patients. You did your research on this very much, that we have both. We have the sensitivity of the dysregulation in the body. In the pain patients, it's being more sensitive to pain. Yeah. Or here, this is fatigue, but this is also related to mental, but not only because I'm sad of the situation, but we have some mediators that are involved in that. So I think in the long, especially in the long COVID, those are two sides of the medal. It's a little bit different in the third group I mentioned that has a stress syndrome from the situation of the lockdown. But those who have the dysregulation and the sleep disturbance and all these things in the long COVID, it's both. It has mental and at the same time physical aspects. Okay. Just sorry, commenting, I did not understand what you exactly said.
No, it is very important also because I just explained because this question actually in Indonesian language, what should be the fatigue is, I also do not know. That's why I asked our colleagues in Indonesia, what is it? But nobody answered it. And then the other issue is, I explained them because last year I was asked by the colleague in one of university in Indonesia to include rehabilitation assessment in general.
Yes.
Yeah. And then I asked why there is no related question related to the mental health issue. I think this is important. They did not start it because they feel Indonesian patient a little bit afraid to express this one. And then I said, but it is very important. We should start, and then we can have the rehabilitation intervention holistically. I said,
exactly. But that's exactly the understanding. And I think those physical rehabilitation specialists that are here, you need to spread this out. That we cannot say a mental problem is separate, or they need to go to the psychiatry or something like that. This is one issue, but we have a strong relation of the feelings of the energy, depressive, or also anxiety, sensitivity, which is closely related to the physical dysfunction. So, for instance, you see this in patients with rheumatoid arthritis. You see, patients with rheumatoid arthritis, they suffer from pain, they suffer from joint problems and things like that, but they also feel fatigue, they feel less energy. So we have the interreaction or interrelation. And what we do here in Hanover Medical School, all the patients fill in as a screening instrument, just a screening instrument, the hospital anxiety and the depression scale. But you can use others as well, because we need to know the interrelation. What I feel is very important here is the understanding why it is like that.
Yeah.
And this is maybe the key also in physical rehabilitation, is the autonomous regulation. We have the autonomous regulation that is included in the blood pressure regulation, in the regulation of other functions like respiratory functions, but also sensitivity of the skin. So many of these body functions are part of the autonomous regulation. And the autonomous regulation also has influence on mood and others. So the key I see there is to be aware on disturbances of the autonomous regulation.
Yeah.
And then we look like that, then the mental problems or the psychological problems may not be just psychological. They are part of the let's say it's kind of holistic view or view on the regulation. And that's why this is always included. And we should not say this is a patient for psychiatry, this is a patient for the physical aspect. And I think the key is autonomous regulation. What we should develop also at the international level is the assessment or even the diagnosis of the autonomous dysregulation in our treatment concept.
Yes, that's very important. Thank you very much, Dr. Gutenbrunner, for more explanation. Here we have another questions from Dr. Who is this? Please, Dr. Nurul Paramita, could you please open mic?
Yeah, thank you very much. Thank you, Prof. Gutenbrunner and Dr. Boya for the opportunity. Can you hear my voice clearly?
Very
okay,
clear.
Thank you very much. Because it's raining here in my home right now. Yeah. I'm very interested. I am a physiology teaching staff at medical faculty Universitas Indonesia, and I'm also a physiatrist. And I'm very interested in the COVID-19, especially the long-term COVID. And I would like you to share how do you, in Germany, how do you treat the long-term COVID patients? Do you set up a specialized outpatient clinics for the patients? And I read that because this is a pandemic era and so many people afraid to go to the hospital routinely, they avoid to go outside. Do you set up a tele-rehabilitation or something like that in Germany?
Yeah. Thank you for this question. It concerns the kind of issues we really have to fight with. The one is, yes, we need specialized centers for that. Because as I explained before, there is a very multidimensional and it's also new. So we cannot say there is a standard pathway everyone can use. So we need specialized centers. And in Germany, we have, for instance, outpatient services like in my department, but we also have inpatient rehabilitation centers that now specialize for that. And we have a certain discussion sometimes because some of rehabilitation or many rehabilitation centers in Germany are organ specific. So we can say, is the patient should go to a neuro rehab? Should he or she go to a lung rehab or another rehab center? And that's why we feel it is so important that a specialized center makes the management and then maybe can refer to others. So the role of the PRM and the centers we have here is on the one hand to analyze the individual situation, which can be different, to see what is the most dominant, the leading symptom, and then to decide what the rehabilitation pathway will be. And what we see, what we observe in Germany, that many patients we see here, they had been treated by the family doctors, by others, and they told us no one really could deal with the issue. So they say, well, yes, we see you are sick, but we have no standards for that. And then they come here, and then we apply our standards, as I explained for this is very important. So we work in the direction in Germany to have the specialized centers, which could be PRM, but maybe some others also could be included in there, maybe multi-professional, maybe you know, the criminologist, the psychologist, the neurologist, and the PRM together, and then give the pathway. The second one we did not implement this, but maybe also for Indonesia it could be very relevant. We need networks. So, for instance, if you have a patient in a rural area and see how he can be managed, he cannot go because it's too much effort to the center, maybe via video conferences or things like that, you can clarify some of the problems. But that's future. That's very important for the future. With regard to the direct treatment you mentioned, yes, we have a list. I cannot go through it now because it's too many single points, but this is oriented, and I think you also know if you have the smell problem, you make the smell training. If you have the sleep disturbances, you apply what you normally apply also for sleep disturbances. So this is for the direct treatment. But I really feel that we need to improve the system of services we have here. And we should also talk, and you mentioned that I'm also thinking about the systems. We have to explain our authorities that it is very important to have the vaccination, to have the prevention of the COVID, but some of the money or the investment also should go to improve the services for long COVID. And that's what we also say within the Global Rehabilitation Alliance that has been mentioned by Boya in his introduction.
Yeah. Gimana, Dr. Nurul? Do you still have another question, or it is not satisfied yet? Please.
Or also talk about your own experience.
Yes.
No, my experience is very limited in this COVID-19. Although I'm very interested. Actually, I'm right now I'm pursuing a doctoral degree, and I plan to have a long-term COVID as a topic for my dissertation.
Very good.
Yeah, thank you very much. And if I can have a second questions, can I have a second question?
Please.
Yeah. Do you think you said about dysregulation, autonomic dysregulation that happens in long-term COVID? Do you think there is a possibility also that there is some hyperinflammation happenings that contributes to the long-term COVID symptoms?
Hyperinflammation contributing to the long COVID.
Yes, yeah, and very, very important, because I think this is important to understand the mechanism. What we think is needed in the research, and we try to bring those data together. It's not so easy because we have the data on the rehabilitation, and then we have some knowledge about the initial immune, but due to data protection issues in Germany, it is very challenging to link both of it. But it would be extremely important, and my hypothesis is that the immune storm after the infection, which is very severe. So that's why also we have the corticosteroids that work in the acute phase, because some of the symptoms are related to the hyperimmune response to the infection. And what I think that the intensity of the hyperimmune response may be related to the long-term COVID. So there is a hope. For instance, if we treat this sufficiently, maybe we have less long COVID. But this study has not been done. And for Germany, I'm a little bit unhappy with the German data protection regulations that are very strict, and it does not allow us to bring the data together. That's a barrier for the German research, to be honest. But as a research question, maybe this is the most important one.
Apakah riset tentang ini, Dr. Nurul,
Rencananya sih sebenarnya risetnya adalah ingin mencoba untuk membangun, tapi masih micro scale. I would like to try to implement on the micro scale on one hospital based the hybrid rehabilitation system for long-term COVID patients. Hybrid, so I would like to also use telerehabilitation, but I would also like to pursue to measure the inflammation biomarker on the patient to know whether or not there is a possibility that the long-term COVID is actually a hyperinflammation process.
Yes. Well, but I'm very glad to hear that you are taking these initiatives, and maybe we also can correspond later, or Dr. Boyer.
Yes, please.
Will help us to have the contact. I'm of course happy to share also, for instance, our set of questionnaires we have here, but then we also need to think about if some of it should be translated into Indonesian language. Some of the standard questionnaires you will have in Indonesian, but we developed a specific questionnaire for long COVID.
Yes, I've read the publication about.
You read it already? Yes. Okay.
Yes, yes.
Maybe we need to think about collaboration to translate this into Indonesian. Yes. Maybe you also can publish it in Indonesian. I'm very happy to collaborate in these issues. And
I will contact you both later if I may.
Yes, very good.
Thank you very much for your question. Yeah, actually, Dr. Radiana also already contacted me, Dr. Nurul, about this issue. Yeah. Yes, of course, I would be happy if we can help you. Yang lain, Dr. Aguswan, terima kasih banyak udah hadir juga. Yang lain, jika yang mau bertanya, silahkan bisa langsung open mic. Ini ada penjelasan untuk Dr. Bonapardede ya dari Dr. Elina. Beliau menjelaskan istilah yang digunakan untuk fatigue di Indonesia, kelelahan kronis yang berlebihan katanya. Mudah-mudahan bisa membantu. Kalau di Jerman biasanya disebutnya Müdigkeit. Yang terkait dengan assessment tool-nya, questionnaire sendiri sebetulnya banyak. Kalau di penelitian saya sebelumnya, saya menggunakan biasanya fatigue severity scale. Itu sudah saya sering gunakan, dan mungkin di sini Dr. Erina juga menjelaskan ada MAF, multidimensional assessment of fatigue, itu juga bisa digunakan, tapi saya nggak tahu apakah sudah ditranslate ke bahasa Indonesia. Silahkan kalau misalkan ini bisa menghubungi Dr. Erina juga, Dr. Bonapardede ya. Anyone who would like to ask another one? Or do you have any other issue that it is important and maybe relevant for the rehabilitation of COVID?
Well, we discussed already many points, and I think we also touched the most important issues. And I'm very glad also to see that you're very much interested. You also have the scientific and the approach also for the treatment and to improve also physical and rehabilitation medicine's role in this one. I think this is very important. It's not only important that we say it's for our specialty or something like that, but we really have to be aware that we have the tools to solve this or to deal with this problem. And I feel this is very important to make this available for as many people as possible. We also have to be aware that, well, I mentioned this now at this moment, it's a scientific-based pragmatic approach, but this is the best way we can do it in the moment. I had a discussion here with the health insurance in Germany, and they say, well, I asked them, are you going to pay for the high amount of interventions? There is a regulation, we can do it in some way. But then, for instance, I discussed, should we have a day clinic for long COVID? They say, well, if you can give us a study, evidence-based study, then and prove that it is effective, then we will pay it for you. And I said, No, that in this moment cannot be the way. We cannot wait 2 years to make a study and then start helping the patients. That's weird. That's not what we can do. That's maybe my message. We need to be pragmatic, effective, listen to the patients, see that this is not only one syndrome, it's more than one symptom, and then we can do it. And well, at least if you start to do this, it is already important for the patients, because in many cases, I don't know how it is in Indonesia, Germany, many doctors say, I cannot do anything. And that's definitely not true. And that's why I think it is so important to have care services for these patients.
Yeah, okay, thank you very much. But I do not know in Indonesia if the rehabilitation for COVID patient is already integrated and become regulation under the badan Satgas COVID ya, saya nggak tahu istilahnya di Indonesia. But Professor Gutenbrunner is a pioneer that in the end the regulation at the state of Lower Saxony approved that rehabilitation should be part of treatment for COVID patients. Yeah.
Yes, essential part.
Essential part. And then regarding the telerehabilitation in Indonesia, because I discussed several months ago with Dr. Melinda from RSCM, telerehabilitation is available but cannot be covered by the insurance, unfortunately, in Indonesia. Maybe this also should be discussed with the BPJS in Indonesia, so everyone do not need to be feared to be treated because they do not need to come to the hospital, but still can be treated at home. Yeah, this is also important. Yeah. So, Professor Gutenbrunner, it seems there is no other questions from the audience. Yeah, and you also already explained so many things. And now I usually ask the last questions that maybe it is easy for you because you already done rehabilitation in many levels. So what your suggestion related to the rehabilitation for at the government level, hospital or physicians, and also for the society? It is short question, but really encompassing many.
Yes, this has many aspects, and I think the first one is on the individual who's affected by a severe disease, as it is COVID, or a long-term sequelae. It is very important that we support the patients also in their daily activity, in their participation. And this, of course, is related to treat the body or the body functions in the disease itself, but to have the more holistic approach to really be aware what can help people to have a good quality of life in these situations. So that aspect is very important, and that aspect sometimes is lacking in non-rehabilitation specialists, let me say like that, that they do not see this holistic approach. You mentioned for the society. I think it is also very important if we see that now from the long COVID, a relevant number, a high number of young people, middle-aged people will drop out from the workforce because they are severely affected. And this has an impact on society. If you have a big number of persons that cannot work, this even could have an economic impact on the long term. So this is from the society, and I also feel from you mentioned the political level, what is the task for a politician or a government, for a government. The task of the government is to create services for the population or the subpopulation that need these services. And we must explain them again and again that rehabilitation is one of the services that is needed in the population for many people. And we have the background from the WHO that clearly explains that rehabilitation is part of universal health coverage. Okay. And we have to explain this to the countries again and again. That's why we're also trying to advocate for a WHO resolution in this context to say this is needed, and this is a responsibility of the government, of course, the responsibility of the medical doctors, maybe the peers, the society as such, but also for the governments.
Yeah, so maybe one of the other issue that need to be concerned by the government, they should not only focus on the number of patients who already cured, do not need acute treatment anymore, but they also should start focus from now for the long term, because in the end, it also will affect the economic situation of the country. Even, yeah. So I think because there is no other questions, I would like to thank you very much, Professor Gutenbrunner, and also to all audience for your time also and sharing your experience and expertise also in this discussion. I hope I think we already got many benefits from this discussion also. Particularly me, I learned a lot from this talk. And please don't forget to subscribe to my channel. This will be uploaded also in my YouTube channel later. And then on Sunday, I will have another program with Dr. Rizky from RSCM. It will be about the feeding difficulties in children. And maybe in the future, I would like to have also maybe a doctor who could explain or share experience how to handle the difficulty to stop eating for adult, because it is my problem actually. So yeah, okay. Semuanya terima kasih banyak, Profesor Jaya Laksmi, Dr. Nulur, Lei Jiang, thank you very much, CSA. And then for other also, I cannot mention all of you because it's quite a lot. All my friends and colleagues, thank you very much for your time. So I wish you a nice weekend. Assalamualaikum, selamat sore.